So, dear colleagues, for locoregional treatment for HCC, this may be for some of you a daily problem. How to decide when we will give our patients or propose TACE or perhaps radioembolization. So I have chosen this topic amongst this jungle of all these locoregional therapies. This was reviewed. This is important that you stage your patients properly. You may even not agree with the system or with the choices that are proposed, but it's important that you have a proper staging of your patients according to this system. And we will talk about the intermediate and the advanced stage. Only a few remarks. First, something about TACE. It remains the standard of care of intermediate stage HCC. In some places, it is still done with the classical in-oil emulsion of anti-cancer drugs, followed by embolic agents. And every institution may have his or her own system. The recent developments of the super-selective injection or drug-eluting beads have changed somewhat, but I return to these initial publications from the Barcelona group many years ago, pivotal trials that have clearly shown that there is a survival benefit of chemoembolization versus conservative best supportive care. So it's important, there is a survival benefit, even if these trials were in fact small, and they included not only patients with intermediate HCC, but also with advanced HCC. But there was a survival benefit. What is important, and these data come from detailed pathological analysis of patients who were treated with TACE, that when you treat lesions smaller than 2 centimeters with chemoembolization, you have about 60% necrosis of the lesions. When they increase in size and are more vascularized, you increase also the rate of necrosis. But especially when you go super selective, you can achieve very high necrosis rates, so very high responses in those lesions. So these are these beads that are about 300 to 500 micrometer in diameter. And the most important aspect of these beads is that you limit the systemic exposure of the chemotherapy. And so you limit the effects on bone marrow suppression, alopecia, and you increase the quality of life. And what is important is the timing of the evaluation of the response in the different studies. So I listed here a few studies on these drug-eluting bead TACE. And when you look after 1 month, you can have a 100% response. When you look after 8 months, you only have 20 anymore. So if you talk about response evaluation, you have to agree at which time you have to look for the response and to decide how to continue or whatever. So I fully agree with Jordi that keeping on doing TACE without knowing what you are really doing is of course not the way we have to treat our patients. But the timing of the evaluation of the response and how to assess needs attention. I don't fully agree that our patients only want to live longer. There is something else in life, and that is hope. For example, Belgium will play tomorrow a quarter-final to Wales, and we have a hope that we can be in the final. And this hope is far more important than these 2 weeks of life we have to go. So hope can in fact be far more important. And hope about the possibility of a cure. This is not rational, I know. But for our patients who are in the clinic with a large HCC, and if you can really treat them by a device and you can have some shrinkage and you can offer them the possibility of a transplant, this can make a total different atmosphere in your clinic, with your patient, whatever. But at the end of the day, what have you done? You may have killed patients in that process. And so this is just a summary of 2 extremes in the literature, that you can downstage your patients within the Milan criteria, but that you reach transplant in 67% and in the others only in 10% of the cases. With some, and in fact we don't know, there is no good evidence that downstaging is indeed something that's even giving something. It would even, if you would have treated your patient at the start beyond Milan and transplanted, it would perhaps have given the same results. We really don't know whether this would make a big difference. But anyway, the whole algorithm on HCC is determined by, can we offer these patients a transplant, and all the therapies really should be looked at, can we downstage or whatever. But the evidence is in fact not so fantastic. Do we need the chemo component in the TACE? Is transarterial embolization not just enough? And really, there have been some studies looking in intermediate stage HCC and in early stage HCC that are suggestive that when you add the chemo, you have some gain in TTP or you have some more histological necrosis. That's true. But then we have this study that was published in GCO from the group of Abu Alpha, where they have randomized patients between blend embolization versus chemo embolization. The advantage of this manuscript and of this work is that they have a detailed description how the procedure was really done. And this is difficult to read, but I just want to mention that the study randomized approximately 100 patients, so a small study. And you have a mixture of BCLC patients, and you have also a number of advanced patients in this study. The net result is that there is in fact no big difference in response, either at the local level or at the patient level, and there were patients with extrahepatic disease also in this study, so this is not clearly limited to intermediate HCC, but on the basis of response, whatever, and all the methods are here listed, modified resist or resist, no difference at all. And when you look to progression-free survival and overall survival, there seems to be no added benefit of the chemo component in this embolization procedure. Adding Sorafenib to TACE. Well, this year at the ESCO, we had a confirmation that the SPACE trial that was published and presented years ago and published early this year, in fact, that these data are true. When you randomize patients, more than 400 patients, either to placebo or to Sorafenib, and you all subject them to DEP-TACE, well, and this was a poster presentation at ASCO, the overall results are that there is no benefit of combining Sorafenib with drug-eluting bead TACE, and this is a confirmatory trial that Sorafenib is in fact ineffective in this setting. What about radioembolization? It's very popular, especially because of the fact that this procedure is thought to be not to be an embolizing technique, that there is no pain afterwards. I'm not completely agreeing with that. There are important side effects. It's a huge logistic undertaking for a center. But in fact, this is the same magnification as the liver I've shown before. So the particles are much smaller than the drug-eluting beads. They penetrate very deep into the liver, and they can even go to the peribiliary plexus in the liver. We know that small lesions in explant studies can be necrotic. In small lesions, they can be easily become necrotic. Larger lesions, they have only a partial necrosis. Most importantly, you have to wait a couple of months to really grasp the full response of this technique. So the mode of action is radiotherapy, and we know that the mode of action, to have the full response, you have to wait several months. This may be because of immuno-oncological reasons or whatever, but it makes no sense to do radioembolization on the Monday and transplant your patients 3 weeks later. So the full response can only be appreciated many months later. What about radioembolization versus TACE? And I go back to this downstaging. There is some suggestion. These are low-quality studies because they are small, not always prospective, some retrospective series, but the profile of a patient with radioembolization differs from a patient with TACE. Most of the time they are a bit more advanced in the TARE studies, more portal invasion, more multifocal, more infiltrating, but nevertheless, from these studies, there is the impression that you have more downstaging with radioembolization than for TACE, but this has not been properly studied. This was a retrospective study presented at ASCO this year, really comparing segmental radioembolization versus TACE. Retrospective, but very interesting data. Comparable groups of nearly 100 patients each. They were quite similar, except, again, that the patients in the radioembolization group, that the tumors were a bit bigger, more infiltrative, and they had more portal vein thrombosis, but for the rest, these groups were quite comparable. And interestingly, in the results, there was a better response for radioembolization either per tumor or per patient. These are the survival figures. This was not significant, but anyway, it seems that there is some signal of efficacy that radioembolization in a segmental way, where you can increase the dose until 120 gray in a small lesion, is in fact far more effective than TACE. What about TARE versus Sorafenib in advanced cases? Well, we are now waiting on the results of 3 global pivotal studies, in total more than 1,000 patients. The SARA study in France, recruitment was completed already a year ago, and then the Sorafenib and the Soramic study. So the Soramic study tested radioembolization followed by Sorafenib versus Sorafenib alone in patients that are not good candidates for TACE. The SARA study randomized patients with advanced HCC to radioembolization versus Sorafenib. And the Sorafenib study has the same design as the SARA study, but now is run in Asia. So we hope we have the results of these major trials that will give some extra evidence and the needed evidence in the field of radioembolization in the next few months. So in conclusion, dear colleagues, TACE is challenged as the standard of care for intermediate stage HCC. I believe that transarterial embolization may be as effective, and that the chemo component, I'm not very convinced that it is really adding significantly. Selective TARE is potentially more effective, but we need more data before putting this in daily clinical practice. Sorafenib is challenged by radioembolization as the standard of care in advanced HCC, but we need the results of large phase 3 studies. And there is no role for Sorafenib in combination with TACE. We have now 2 studies that make it unlikely to go for another phase 3. And I didn't talk about that, but it is my strong belief that studies on the combination of locoregional therapy, external beam radiotherapy, TACE, radioembolization, and immuno-oncology agents, this is really something that's very promising, I think, and needs to be investigated and will be investigated. I thank you very much for your attention.